Hello, this is Dave Hagedorn. I appreciate you all taking time today to join this meeting. I know it's early on the West Coast. It's 7 o'clock my time here in North Carolina. And I want to talk about heart rate variability. It's a big topic and it seems simple. There's consumer grade equipment out there, which does make the complex a little simpler. But we're going to do a little deeper dive, mostly because of the physicians on this meeting that utilize this assessment and treatment modality. I want to help you understand it in a little greater depth today. Let's see here. We should be trying to share my screen with you here. All right, you should be able to see my screen. If not, you feel free to send me a text if you'd like. So the first thing I want to basically cover is whenever we're treating a patient with whether it's cognitive related conditions, central nervous system problems, we should not ignore the autonomic. In other lectures, we've talked about the enteric nervous system also being very important and integrated. But today I'm just going to camp out on the heart, and in particular, the heart rate variability measures that you get from an EKG or a blood volume pulse measure. The seminal medical paper that's internationally respected, back from 1996 when this was published, remains to be kind of the go-to document for explaining all things HRV. So it's a must-have, a must-read, and it was basically put together by a task force after really 20 years of heart rate variability research. It was recognized that there needed to be some international standards, and in fact, that's what took place. And the flurry of research articles since then are reflected really in large part by the work that was done by this task force. Heart rate variability is used in many major hospitals, if not all. Military uses it at their highest level facilities, their peak performance facilities, also NICO and elsewhere, because it's recognized to be so helpful. It's used at pain clinics. Mayo's got many programs that involve forms of biofeedback, et cetera, Cleveland Clinic, et cetera. So it's well respected, well understood to be of great value, not only the assessments, but the treatments that stem from that assessment. Heart rate variability is basically this very simple way to provide a window into the function of the autonomic nervous system. When you have low heart rate variability, you have increased health risks. That is well known, well understood. It's low cost, it's non-invasive, and it gives you results that inform different treatment options, whether it's medication or non-medication options for all ages. The heart rate is under both sympathetic and parasympathetic control. And when you have rapid fluctuations in heart rate, that implicates the parasympathetic control portion. When you have low heart rate variability, there are several correlations with that. You have correlates with physical and psychological stressors, different diseases like depression. There's the autonomic imbalance due to deficient vagal inhibition. It is implicated in increased morbidity and all causes of mortality. Heart rate variability when low is a marker for cardiovascular disorders, such as ventricular hypertrophy, ventricular arrhythmia, chronic heart failure, ischemia, etc. Low heart rate variability is a predictor of sudden cardiac death, especially due to the arrhythmia following an MI. They've done research where people have had MI and survived, and those who were trained with heart rate variability biofeedback the groups that had this training survived the second MI, while those that did not train with heart rate variability did not survive. Low HRV is seen with a whole host of anxiety conditions, which makes a lot of sense because of the correlation that we'll talk about with sympathetic tone being quite elevated with the basic dysregulation of the autonomic system. It's used with asthma. A lot of the early research in heart rate variability, a lot of it by Paul Lair in New Jersey, did a lot of great groundbreaking work with asthma and other conditions. OBGYNs are really quite familiar with heart rate variability because it's often the item that they're looking for in the baby while the mom is engaged in process of delivery, to be monitoring the health of that baby, because heart rate variability is an early indicator of distress for the child. Heart rate variability very recently in the last year has been used with quite surprising success in identifying early inflammation in people who had COVID. And it's quite remarkable because it's correlated with an elevated blood CRP level. But we can see changes in heart rate variability days before, sometimes over 70 hours before you'd get an elevated CRP. So the HRV is a precursor or an earlier detector than looking at inflammatory measures in the blood. And it showed to have about a 91% predictive value for the increasing inflammation process. It's also thought that it could be quite useful, based on this research and others, that would be used in triage or caring for moderate and severe COVID patients. And on other research, Dr. Hurton from Mount Sinai, he found that heart rate variability changes and predicts COVID 7 days, a good week before a positive diagnosis by nasal measures, and also found that the heart rate variability will normalize 7 to 14 days post-infection and post-symptoms. When HRV has been used with brain injury, we see a very similar pattern. We'll see it being a very sensitive measure to concussion, and also a good marker for when there's stabilization again in the central and autonomic nervous system communication, the back and forth that takes place. We get normalized HRV, and it probably would be a good tool to use on the sideline before you send somebody back into a football game or back to play because of its sensitivity. HRV has an advantage of giving you good measures, good types of measures that we'll talk about today. And one in particular, which is, obviously a huge problem in America and throughout the world, is diabetes. And we know that the process of diabetes is deleterious, it's problematic, it's inflammatory, and we see autonomic neuropathy from diabetes. We see neuronal degeneration of the small nerve fibers, both the parasympathetic and the sympathetic, as a result of diabetes. So when you're looking at ways to quantify and measure these things, HRV is helpful, but also it's helpful as part of the treatment plan. So you may have patients that you're treating for diabetes and give, glyburide, metformin, etc. Heart rate variability is a useful tool as an adjunct to that therapy. HRV measures you can easily test and retest because it's very inexpensive and fast, and can maybe help motivate some patients for some lifestyle interventions, weight loss, stop smoking, glycemic control, etc. So the stress management, and HRV is very useful in particular for modulating high stress. There is a relationship, as I mentioned at the start, between the heart and the brain. And we see that there are sensory pathways of sympathetic and parasympathetic systems through a loop or a pass through the brainstem. We see the innervation at the point of the medulla, and it also projects to other conscious cortical areas. So it's not just limited to influence at the medulla level, but in fact, the ascending and descending pathways provide a feedback loop through the brain and the heart, making it really the hub of why, when we're treating the brain, we should also be addressing the heart and vice versa. Some really groundbreaking work has been done by the doctors at brain clinics in the Netherlands, where they are mapping the brain with respect to heart rate variability and looking at heart rate variability and the influences of it on different areas of the brain using the TMS mapping technologies. It's something that's quite unique right now. There's several publications from Dr. Arns on this topic, and well worth reading for any of you who are doing brain stimulation work. The integration and application of heart rate variability really is well supported, and in my view should be a must-have. And in fact, in our clinic here, we do require anyone who's doing TMS to also be trained and have home therapy tools for heart rate variability biofeedback. The neural activity from the heart, what we see, travels to the brain through the 10th cranial nerve or the vagus nerve, and it influences different brain centers that are associated with cognition, thinking, organization, decision-making, which are all executive functions, frontal lobe functions. Also reaction time, the ability to focus and pay attention. HRV biofeedback has been used in school systems to help kids with inattention and improve academic performance. The thalamus is involved with innervation from the heart, and this involvement in the brain is really, really important because one of the many roles of the thalamus, as you know, is to synchronize the neural activity of the entire brain, and of course the executive functions being a big portion of that, and that's where most people end up having trouble when they go to see their doctor when they're having brain difficulties. It's typically because of a frontal lobe executive function, or in other cases, maybe it's just short-term memory loss, but the executive component is where people start to have trouble and need intervention. If you can't focus, can't pay attention, can't make good decision-making, have disrupted emotional function, emotional dysregulation, depression, those are the areas of the brain that can be influenced and in many cases improved with heart rate variability training. We'll touch base really quickly on the baroreflex because that's an important piece of this puzzle to try to understand what's really going on with the process of heart rate variability. So in short, there's this feedback loop, and the baroreceptors, they detect changes in the pressure, the blood pressure, and they are activated by low blood pressure. So there's a deactivated baroreceptor reflex then by elevated blood pressure, and that results in a vagal brake. So there's this push-pull process taking place. A signal then is sent from the heart to the brainstem, specifically to the medulla, as I mentioned, and then the signal then is sent back from the brain via the vagus nerve back to the heart to make the adjustments in that pressure. So the baroreceptors are part of that signaling process and that detection process for that feedback loop. We know that when people breathe at a particular respiration rate, somewhere between 4.5, 5.5 breaths per minute in an adult, we are getting some exercise, if you will, of that baroreflex. And when heart rate and blood pressure oscillations are out of phase, which I'll show you what that looks like in a minute, it's basically rather than being in sync or in phase, they're opposite or out of phase. This baroreflex becomes the strongest, and something called respiratory sinus arrhythmia is greatest or at its best. And that's what we try to achieve. We try to get that stronger barrel reflex, and improved or greater RSA is one of the goals of heart rate variability training. And the perfect phase relationship between heart rate and respiration rate results in better gas exchange and better oxygenation, which is one of the reasons why heart rate variability has great benefits to those people with asthma. So again, on the baroreceptors, they are blood pressure sensors located in the aortic arch and internal carotid arteries, and they contribute to, they're part of one of the players in producing or help generating the variability of the heart rate. And how this works is when you inhale, your heart rate increases, your blood pressure thereby decreases, and then your blood pressure will rise about 5 seconds later. There's a delay. The baroreceptors detect this rise and fall, this rise, and it fires them more rapidly with increased rate. And then when you exhale, your heart rate decreases and your blood pressure increases. Then your blood pressure again falls back about 5 seconds later. So this process takes place with heart rate and blood pressure increasing and decreasing, and your respiratory function, your rate of breathing, which is volitional, something you can choose to do and control, has then this downstream influence on heart rate rise and fall, and also corresponding blood pressure rise and fall. So the mechanism to help modulate your variability is your respiration. So let's take a little bit closer look at what's happening when you breathe in. When you inhale, your inhalation will reduce your intrathoracic pressure that leads to increased venous return. Your right atrium stretches. Your right atrial receptors produce a reflex. Then this reflex, in particular, right atrial pressure stimulation of volume receptors in the arterial wall. There's impulses to the medulla, as I mentioned already, and in the brain from the afferent vagal fibers. Stimulated vasomotor sensor that increases heart rate by efferent impulses along sympathetic nerves. So all these things are taking place in a sequential process when you inhale. When you exhale, you have blood from the lungs that enter the left heart and is then pumped into the aorta, increasing arterial pressure. The arterial baroreceptors of the aortic arch and the CS, the carotid sinus, react to this increased arterial pressure. The vagal nerves, which are parasympathetic in particular here, are thereby stimulated, causing a drop in the heart rate as you exhale. So you're getting that exhalation-related drop in heart rate. There's venous return that takes place, reversal of the right atrial stretching. Thereby, you have the stretching from inhaling, and then you get the reversal of that stretching on the exhalation. So that inhale-exhale process is what's generating these changes. Now, RSA, okay, at least often thrown around as an acronym, respiratory sinus arrhythmia. It's a measure of your nervous system health. And the respiratory portion of RSA refers to the influence that our respiration function has on the heart, namely how the increase in heart rate is a residual of the inhalation of the lungs. And sinus refers to the sinoatrial node on the heart. And then, of course, arrhythmia refers to an irregular heart rate pattern. And when the vagus nerve is stimulated, it slows the heart and it dampens the sympathetic tone. No surprise there. In people with anxiety, clearly we have a big problem with high sympathetic tone, and we would like to dampen it, and preferably without medications if possible. And in contrast, if the vagus nerve is not stimulated, you experience more sympathetic activity to include elevated heart rate or that stress response. So we see this with the heart rate variability, we can get a window into how much sympathetic tone is there compared to parasympathetic, which is more of the rest and digest versus the fight or flight, which we correlate with sympathetic tone. In order to measure all this stuff, we need some tools, and there's several tools at your disposal. Obviously, you're aware of the Evoke system because that's who was putting on this talk, and you have a system like this, and it records the heart rate variability through ECG. So typically, you're used to a 3-lead ECG covering the chest, like you have in the center image here. The Evoke system is unique because we're able to use this LA location over just below the left clavicle, and we can use these other points for reference and ground on the head itself. So the cap, when it's on and is gelled, is providing the other points, and that triangle gives us a very clean ECG. But you don't have to use ECG to record heart rate variability. You can also use something called blood volume pulse, which I'll talk to you about. But ECG is a common one. It's generally considered to be a little bit cleaner and more specific for recording the R wave, because you get an actual QRS complex that you can look at, and the math can from the software can identify that peak quite easily. There are other places you can do a placement, 2 on the wrist, 1 on the other wrist. There's different ways of getting that ECG measure. Thought Technology has equipment which uses both. I'm just showing an image of it here. Thought Technology is an excellent biofeedback company out of Canada. Their equipment is used worldwide, and Evoke very much supports and encourages their products as well because of their high quality. A lot of physicians' offices and hospitals use this type of biofeedback equipment. This is a sensor here. It's a sensor for recording the EKG, and you can get that information there. And then they also have equipment that will record blood volume pulse, which I'll show you. But with the EKG, we're mostly interested in the R peak, right? So when a large portion of the heart contracts, we're getting that cardiac function that's taking place there is what's generating this peak. You all see the schematics of what wave is associated with which portion of the heart pumping. And we're interested really in just that R wave for our calculation purposes, because we're interested in how much time it takes between one peak and the next. Now, blood volume pulse is different. This sends a light in through the skin, and the light then penetrates. It has a photo detector that will penetrate and see this change in blood movement. So you get this large wave that's recorded at the moment the heart is pumping blood, or the pulse. And the blood pressure and the capillary vessel diameter changes at that moment, and that represents a pulse. And the light sensor can detect that change in the vessel. So this PPG, or photoplethysmographic sensor, records this wavelength that passes into the vessel, detecting that increase and decrease in the light wavelength, and that generates a wave. Now, it's not an R wave, but it's correlated with it. There's 2 little waves that take place during that pulse, and these sensors record the highest amplitude first wave. And it's correlated highly with the R wave, so that you can do the same mathematic formula on the difference from R to R. So heart rate biofeedback has 2 pieces that we look at. Think of it 2 sides of a coin. We have a time domain measure, and we have what's called a frequency domain measure. And we're interested in both. The importance of both for heart rate variability assessment are clear, and I'm going to talk about each of them now. So the time domain is quite simple to grasp. It's basically time. How much time does it take from one peak to the next? And we can do statistics based on that. We can say, okay, we've got so many milliseconds from here to here and from here to here and so on. And then we can do statistics like a standard deviation, which is a singular value that tells you how much variability you have in your numbers over time. And that's a common statistic, and it's what's reported in most cases. There's also something called a root mean squared, another type of standard deviation, a difference measure, commonly used, and they give you some time measures of variability. And those are tremendously useful because we have norms for that. And basically, you've got a person who has an SDNN score, say below 50, they have problems. It's correlated with poor health. And there are different periods of time that you can do this recording on. So there's Holter monitors that can be worn 24 hours, even 30-day monitoring is done. They're a little bit different. There's a little more nuance to looking at a very long range, 24-hour recording versus a short one. We have good norms for 5 and 15 minute, generally 10 and 15 minutes, a little bit better, more stable time period for looking at heart rate variability changes than 5. 5 is kind of the lower end of the time spectrum to have enough samples. But when you improve this number, you are in fact improving health. So when you have a patient that has an SDN of 100, that person has a significantly lower risk of mortality than someone who has a score of 50. Because there's importance of respiration, as we talked about earlier, inhaling and exhaling, we also need to be monitoring inhale and exhale process for to develop a synchronous wave, a sine wave with respiration, because that's what's driving that increased heart rate and decrease of the heart rate. And in fact, these waves often are confusing to people. People will see a blue wave on a feedback screen and think it's respiration, when actually it's not. It is this calculated equivalent beats per minute formula where the computer will look at the difference between one hour peak and the next, and it'll calculate what a beat per minute would be. Typically, it takes about 30 seconds or so of recording data to start to generate the math to build up and start plotting this information. So this difference in time would say, okay, at this rate, the person's heart rate, it would be, say, 63. And at this rate, it would be a little bit higher and so forth. So the computer will take these differences, and you notice here, when you have a big wider variance here in time between one hour peak and the next, you see a pretty rapid, dramatic drop in heart rate, which makes perfect sense. If you have a lot of distance, it'd be a lower heart rate. So this is just a calculation that plots these individual calculated beats per minute on a graph like this, and it produces a wave. You can see when you inhale, the heart rate's going to climb, and when you exhale, it's going to go down. So these little dots, these R to R intervals, are then identified and mathematically calculated for the beats per minute. They're then plotted, and then a line is drawn between them to create what's called a wave, or a waveform. The SDNN I mentioned already, it's a standard deviation of R to R differences over time. And when we remove the artifacts, we take the artifacts out, we call it an SDNN instead of an SDRR. But there will be times when you'll read SDRR in the literature. Sometimes that is an error by the person writing it, but their SDNN is typically what's reported, and it's an R to R difference without the artifacts. And a shift from low to moderate SDNN can decrease mortality by 400%. And there are many, many applications for recording, but generally 10 minutes is a pretty good amount of time to have very stable data Somewhere between 5 and 10 is probably about the ideal, between not taking too long and still getting robust recordings. The RMSD, or the root mean square of the successive R to R intervals, is another commonly used statistic because it's a very good measure when you're looking at very short amount of time. Like if you're only measuring 5 minutes, probably the RMSD is a better statistic than the SDNN to use. And there's been a lot of research on looking at the RMSD on like wrist-worn devices like the Apple Watch and the like, because it's a good statistic for shorter periods of time. What's interesting when you look at the research, sometimes you'll see ranges of norms. Now I show you this because these norms they're terrible. I wouldn't want to have patients that have an SDNN at 50 or an RMSD at 42. The range is good. I mean, there's some people up in the 90s. That's great. That's what I'd like to see. But there's some people in that population that were tested were at 32. So just because this is a norm, an average, does not mean it's a good average. We would prefer people being around 100 for an SDNN. Now, yes, it's correlated with age. These numbers do drop with age, but that's just because that's quote unquote normal doesn't mean it's good. So frequency domain information is what we then can look at next. So we talked about the time domain, that's SDNN, RMSD, basically the R to R difference variability. And again, that's right, you can control that by having paced diaphragmatic breathing. There's an additional measure with heart rate variability called the frequency domain. The frequency domain measures and quantifies that distribution of absolute and relative power into different frequency bands. So heart rate variability frequency domain measures their calculation of these bands, and these bands have names: ultra low frequency, very low frequency, and high frequency. Not everybody uses the ultra low frequency, but often it's assumed within the very low frequency band, and they have meaning. The very low frequency side is correlated with sympathetic tone, and the high frequency parasympathetic. The goal is to have dominance in the low frequency zone. Okay? And we can calculate the power or amplitude using math where it's expressed in milliseconds squared divided by cycles per second. That's power. That's the measurement of the heart rate variability frequency, which I'll show you in a minute. And then all of these bands, whatever that amplitude is in all those bands collectively, that is your total power. So you'll see heart rate variability total power. All that is an aggregate of how much is in each frequency band. So it's spectral analysis which comes to the rescue for helping us figure out how to basically filter all of the oscillations that are taking place with the heart rate increase and decrease, and that pattern. There's something called fast Fourier transform, which is a mathematical method, an autoregressive method that can take that wave information and filter it out so that we can put them into different frequency bands. And this is quite useful in partitioning out the total variance in heart rate into these underlying rhythms that occur at the different frequencies. These frequencies can be associated with different conditions, and we see a very rapid response in frequency change even when you ask a patient to look at a picture that's, say it's of a person that's distressed or sad. You'll see a very rapid change just from what somebody looks at that's maybe a depressing looking photo to changing what's happening in the heart rate variability at the frequency level. You could see it nearly instantaneously. So this is what it would end up looking like. So you get an FFT that has an X and a Y axis, and the very low frequency side here on the left is more sympathetic when it's dominant, okay? And we would like to see higher power here at the low frequency range. And if you see dominance here in the high frequency range, it's more correlated with parasympathetic dominance. So obviously when you have parasympathetic dominance, your heart rate's low, respiration's low, blood pressure's low, and heart rate variability is elevated, high. When you have sympathetic dominance, your heart rate's high, respiration's high, blood pressure is elevated, and heart rate variability is low. So the objective is to have it in this middle range, somewhere around an SDNN score of about 100 with good power around 0.1 hertz, which is low frequency power. And this is how this is done. To break that down, we basically take something called a rhythmogram, which takes that R to R series waveform activity, that wave data, through spectral analysis, it breaks it up into the different oscillation speeds. So we can break it up by frequency. Very similar to what happens with EEG, how we break up that all that rhythm into the different frequencies. Now it's counterintuitive, but the slow oscillations from the rhythmogram data, from the R to R series data, that is correlated with sympathetic tone, where the very fast frequency, these fast oscillations, that's correlated with parasympathetic. So when it comes to EEG, it's kind of the reverse when you think about it. So this process then moves from the filters, and then that generates by taking these different frequencies and looking at the amplitude of all those frequency types. That's how you transfer that into an FFT, with an amplitude here in this particular example, a higher amplitude in the very low frequency than into the high and low frequency. See dominance and very low frequency. So that would be more of the pattern you would see when you split this up. Here's another way of looking at that data. This is important here because it's able to show you how the different respiration rate that's again, it's volitional, can impact your frequency. So if you start here on the left, so if you breathe in at 5 breaths per minute, or 12 times per minute, a breath pattern of 5.0, okay, which means you're inhaling and exhaling 12 times per minute, you would produce a sine wave like this. Okay, so you know that many respiration pattern, inhale, exhale, 12 times every 60 seconds. That's a cycle of 5 breaths. Now, if you did that pattern, you would generate 1/5 cycle, okay, 1/5 cycle, you would generate 0.2 hertz right here. So it's a little bit more to the parasympathetic side at 5 seconds by math, okay? And if you were to breathe at, say, 12 breaths instead of 5, then you would be generating a frequency much closer to the left of 0.1. 6 breaths per minute happens to correlate with 0.1 hertz. And so the respiration pattern for generating a 0.1 hertz is generally found to be around 6 breaths per minute. But it gets a little trickier because there are some individual differences. Not everyone can generate their maximum power at 6 breaths per minute. Some people it's 5.5, others maybe 6.25, and so on. So a little bit of individual difference to have a respiration pattern that's perfect to maximize RSA, to maximize your resonant frequency. This is not new science, as I'm pointing out, by Wagner's research in the 70s. This is the work that really kicked off the 1996 task force, because a lot of the work on autonomic balance was done back in the 70s. So resonance, just in general terms, is a system that has basically 2 processes or functions in the system that have a feedback relationship, kind of like a pendulum has a relationship between its movement and the gravitational pull. So when you drop a pendulum and it swings, there's a relationship to gravity. It's not functioning in a vacuum. The resonance in the cardiovascular system, we realize is in place too, and that's that respiration and heart rate working together as two systems. So when you're breathing at a certain frequency, you get your highest amplitude of both heart rate and blood pressure. So some people can breathe at 6 breaths per minute to maximize the range of their heart rate, the amplitude of that heart rate, and blood pressure oscillation, while others maybe have to breathe at a little lower rate, say 5.5. But when you are breathing at your resonant frequency, when you can identify what your frequency is that's unique to you, you are in essence having the best training of the reflexes of the cardiovascular system, and particularly that baroreflex. So the challenge then is, how do you figure out what your resonant frequency is for your respiration? Because that's going to drive and have the most benefits. Well, we know we get this relationship between the respiration rate and the heart rate. And this is kind of what it looks like. When you inhale, your heart rate goes up. When you exhale, your heart rate drops. That's here in black. And when you do that, and then you can then monitor your heart rate rise and fall. And if it's in phase, notice that these are in phase. The fall of the heart, the respiration or the exhale is in phase with the decline of the heart rate. And as you inhale, the heart rate climbs. Now you're in phase. Okay, that's the target. That's the objective. Now the blood pressure is 180% out of phase from the heart rate, and that's to be expected. So that's what it looks like when your blood pressure is out of phase. But this in-phase relationship is the goal. So when you have equipment that will help you monitor that, and you can see it on a screen, you can adjust your respiration rate so that you develop this in-phase relationship. And it would look like this. So this is an image from software that shows the respiration rate is in blue. Person's wearing a stretch band around their upper abdomen. So when they inhale, the blue line goes up. When they exhale, the blue line goes down. And then here's all that heart rate increase and decrease. So this is an in-phase relationship that you're trying to generate. And that generates what's called a resonant frequency. The resonant frequency is that respiration pace that is in phase with your heart rate wave and maximizes the low frequency power, which is our goal. And it's somewhere around 0.1 hertz in most people. So in this case, it took this person a rate of 5.5 to generate this high dominant peak. That's just a little bit south of 0.1 hertz, okay? Just 0.092 is where it ended up getting the most dominant peak. And so that person's respiration rate to generate this resonance and is at 5.5 breaths per minute. 4.5 didn't do it. You can see how diminished that power is in the frequency at low frequency. Same thing here, 6.5 didn't quite do it. So this particular person, it required a little adjustment. And these are very easy to figure out. There's different home software, consumer devices that can help you figure this out. So heart rate variability, it is very useful, in fact, to help stimulate the baroreflex, and we know that that's valuable, and you can train it quite easily. So you may start with a person with excess sympathetic tone, like here on the left, and with some training, they can generate a very good power at low frequency. And that's what it looks like. And we're less concerned about interpreting the clinical diagnosis here, although we can guess this is somebody with some sympathetic arousal. Could be chronic pain, it could be anxiety. This person could have chronic fatigue, having both sympathetic and parasympathetic dominance. But more importantly, this gives you a measure of what to change and how you can do some things to make some adjustments in life. Yeah, it's used in athletes all the time. We're seeing a lot of use of heart rate variability even with horses, professional horse racing. They're monitoring the heart rate variability of the horses. Athletes need to monitor this so they don't have overtraining syndrome. It's widely used in athletics. This is an example of a device that's inexpensive with free apps. So you can actually learn quite a bit about heart rate variability by just downloading the free app and reading the history and the information section that explains what all this is. So this is just happens to be an app which shows you the pattern of respiration pattern and heart rate rise and fall. It shows you your low frequency power. It tracks your time domain and frequency domain data over time, and it's essentially no cost to people. The Evoke equipment does something very similar on a page like this. You set your pace of breathing, and then you watch as it fills in your FFT, and this is the zone. And once the data fills in from having about a minute of recorded EKG, it populates and you can see what breathing pace generates the most optimal power in the low frequency band. So you know what your respiration pace can be. All right, so that's all I've got for today. We tried to get through some of the highlights of heart rate variability. I hope it's been useful. And the name of one of the questions that one of the doctors had was the name of the Canadian device. The company is called Thought Technology, Ltd. They have a lot of equipment. They have EEG and heart rate variability equipment. And again, we're very happy to have you contact them. And if you have more questions about their equipment, they can contact you, or I'm happy to answer your questions about it too. Anyway, so it's been nice talking to all of you this evening, and I appreciate your attention to this topic, and I hope you'll utilize heart rate variability assessments and biofeedback with your patients.